From one primary care doctor to another, questioning the cholesterol treatment guidelines. I'm Sam Eggertson. I've been a family doctor since completing residency training in 1979. I'm currently working in a community health center. We in primary care may feel we have no great expertise in analyzing the medical literature, but it is incumbent on all of us to evaluate the evidence as best we can that we use in patient care. This presentation is the result of my deep concerns about the cholesterol guidelines we have been presented with, the most recent of which is this one, the American Heart Association 2013 guideline. If we follow this guideline, we will recommend statins to 13 million more people in this country. And the question before us is whether we should resist or embrace this guideline. I'm going to raise fundamental questions about our use of statins and our approach to lipids in general. The disclaimer: this presentation is to raise questions, not to recommend treatment or provide medical advice. The information provided is not a substitute for medical or professional care, and you should not use this information as an alternative to consultation with your physician or other healthcare provider. If you have any question about any medical matter, you should consult your doctor. Always consult with a qualified medical professional before making medication decisions. We are first going to focus on what we believe right now about lipids, statins, and heart disease. We will then review the evidence for those beliefs and finally discuss the problems that the evidence might bring to our patient care. Here are 10 true-false questions. I gave these to my colleagues, and in general they believed the first 3 to be true, but the answers to the remainder were mixed. The purpose of the questionnaire was simply to focus their attention on what they believed about lipids, heart disease, and statins before we discussed the actual evidence. You may want to pause the video and answer them for yourselves. We will come back to each of these 10 questions as we move through the evidence. The lipid hypothesis is now widely accepted by physicians and patients, but what really is the evidence? The first statement that we looked at to have ourselves commit to our current beliefs was this one: too much dietary fat and cholesterol leads to heart disease. Is this a true statement? Is the lipid hypothesis in regards to diet valid? If it is true, how do you account for this meta-analysis? Almost 350,000 subjects, no significant evidence for concluding that dietary saturated fat is associated with an increased risk of cardiovascular disease. And the Framingham study, no relation between high cholesterol and or high fat diets with either blood cholesterol levels or any manifestation of coronary heart disease. And the Women's Health study, almost 120,000 nurses, total fat intake not significantly related to the risk of coronary disease. And the Health Professionals Follow-up study, about 44,000 men, no association between intake of saturated fat and risk of coronary heart disease. And the Women's Health Initiative study, almost 49,000 women, no difference in composite endpoint of coronary heart disease events or stroke over an 8-year time span. And in fact, the women with known cardiovascular disease who were entered into the low-fat group had more myocardial infarctions. And how do you account for the effectiveness of the Atkins diet? A high-fat diet improves the lipid panel more than most other diets. So, too much dietary fat and cholesterol leads to heart disease? None of these studies support this statement. And if there is no good evidence to support it, why do we persist in our recommendations to patients to limit the saturated fat and cholesterol in their diets? Treatment with statins improves mortality in those without known heart disease who have increased cholesterol levels. Is this true or false? If it is true, how do you account for this meta-analysis? Almost 65,000 participants, no evidence for the benefit of statin therapy on all-cause mortality in high-risk primary care patients. If there is no convincing evidence of improvement in all-cause mortality, are there potential problems with the evidence for overall benefit from lowering cholesterol in this group? John Ioannidis is a professor of epidemiology at Stanford, and his article, Why Most Published Research Findings Are False, has become the most downloaded study in the history of the Public Library of Science. He gives a proof of sorts that in modern research, the majority of published research claims can be proven false, a provocative claim. And we aren't going to review this article in detail, but if you are interested, you can download this article. There are two fundamental concerns for the evidence of evidence-based medicine. First, publication bias, and second, bias in the studies that are published. For publication bias, if 10 studies are done on drug X and 2 are positive and 8 negative, and only the positive studies are published, our evidence-based decisions are made on a biased sample. Our decisions may become more bias-based than evidence-based, and publication bias is a serious problem. I need to acknowledge Ben Goldacre for the examples I'm going to give. He's a British physician who gives these examples both in his book, Bad Pharma: How Drug Companies Mislead Doctors and Harm Patients, and in his TED Talk YouTube video, What Doctors Don't Know About the Drugs They Prescribe. Example 1. 7 studies are known to have been completed comparing the antidepressant reboxetine to placebo. 1 of 7 studies showed it to be better than placebo, and it was published. 6 negative trials were not published. Several studies were completed comparing reboxetine to other antidepressants. 3 studies were published which showed it to be equally effective, but unpublished studies with 3 times as many patients showed it to be worse. Example 2. All known FDA trials on antidepressants were reviewed. 37 of 38 positive trials were published, but only 3 of 36 negative trials were published. And example 3. I find this the most interesting of all. Roche had done 74 trials of Tamiflu, but held most of the results unpublished. In 2009, the Nordic Cochrane Group, not finding convincing evidence that Tamiflu provides any important benefit, requested that Roche make all the data available. Roche resisted, but under threats of legal action and bad press, Roche began releasing the data beginning 4 years after the initial request in 2013. The roadblocks that Roche used to avoid the release of the data are discussed in Ben Goldacre's book, Bad Pharma: How Drug Companies Mislead Doctors and Harm Patients. The Cochrane Group finally did receive the clinical study reports from both Roche and from the European Medicines Agency, and this year published their conclusions. They found high risk of bias, missing data, suboptimal measurement, and incomplete reporting, and they questioned the use of Tamiflu as an anti-influenza drug in clinical practice. A rather disturbing conclusion for those of us who prescribe Tamiflu. What we may have accomplished is simply to have given a number of patients unnecessary expense and side effects without giving them any important benefit. Well, publication bias is a very real problem, but an even greater problem may be bias in the trials that are published. I'm going to give a list of 12 red flags for potential bias in research articles. This is by no means a comprehensive list. I've not even included problems with adequate blinding. I think the 12 I have listed will be sufficient for us as we go through specific studies. And the 12 are: the study sponsor has a financial stake in the outcome, the study sponsor controls the data prior to delivering it to study statisticians, the study sponsor owns the data and is selective with its release after the study is completed, the investigators have conflicts of interest, the study endpoint is a composite, which includes soft endpoints combined with hard endpoints to give the impression of significance, and we will find several examples of this. The relative risk is emphasized and the absolute risk is downplayed. For example, if 2 in 1,000 people suffer from disease X, and with treatment only 1,000 now have disease X, this is a 50% relative risk reduction, which sounds far more impressive than a 0.1% or a 1 in 1,000 absolute risk reduction. Relative risk is most often used for the main outcome of the study, making it appear important, but the adverse events are most often given in absolute risk, making them seem less so. Misleading or unjustified claims are made in the abstract or remarks. You may also find statements that impress you more as advocacy than objectivity in their presentation of data. And when I sense an article is more of a promotion piece for a drug rather than an objective presentation of the data, I wonder about ghost authorship. Was the article itself written by the pharmaceutical company to be signed off by the investigators? At the very least, promotional statements give the indication that the authors have biases. The definition of significance is changed from that stated in the design to that used, or the design itself is changed during the course of the study from what was initially planned. Excessive subgroup analysis is used to find significance. The full study group may give results that aren't statistically significant, but if that group is parsed sufficiently, a subgroup might be found for which significance can be claimed. The data generated is not consistent with the disease being studied. That certainly should be a red flag. And number 11, the study is terminated early based on soft endpoints. You might be surprised that early termination is a red flag, but early termination is a major red flag. Early termination has a number of advantages for a pharmaceutical company sponsor. First, it gives the impression of great effectiveness of the drug. You may be impressed that stopping a study planned for 5 years at 19 months is due to the dramatic benefit of the drug and must mean that the drug is very effective. Second, early termination avoids the risk that subsequent data will not be as positive as the initial data. One can't help but to wonder that a sponsor monitoring the study sites and managing the data might also become aware of negative data before it is officially entered. Third, early termination saves a significant amount of money. Multi-center, multi-year trials are very expensive, so early termination gives the impression of great effectiveness, avoids the risk that subsequent data will be more negative than the initial data, and saves money. Another red flag, there may be unreasonable extrapolation of the results to the broader population. The study itself may have been done on a very narrowly defined group, and yet the results are used to justify treatment of the entire population. Now this is my own sign. I call it the red flashing light for potential bias, and I give this sign when these three red flags are present. The study sponsor has a financial stake in the outcome. The study sponsor controls the data prior to providing the data to study statisticians, and the study is terminated early based on soft endpoints, not the hard endpoint of mortality. And to me, this is motive, means, and opportunity to insert bias. I don't know if sponsors have ever acted in response to data as it was being accumulated before its official entry, but certainly the motive and the opportunity are there when these three red flags are present. Before we begin our focus on the specifics of individual trials, we are going to consider this question: is mortality the only hard endpoint? Death is certain, but data as to the cause of death are not completely reliable. Sudden death is often attributed to coronary artery disease, but this attribution may have a significant error rate. In one series of sudden death evaluated by autopsy, 1/3 were from myocardial infarction, 1/3 were from medically identifiable disease such as ruptured cerebral aneurysm or pulmonary embolus, and for 1/3 the cause could not be identified. So the overall error rate for clinically determined cause of death may be very high. In one series, only 53 of 100 autopsy-proved acute MIs were correctly identified clinically before death. And given the errors as to the cause of death, I think it is reasonable to pay particularly close attention to all-cause mortality. Red flags and red flashing lights do not necessarily indicate that the results of a study are biased, but indicate the potential that bias influence the results or the presentation of the results. We are going to begin with two studies referenced in the American Heart Association guideline. First, the LRC, the Lipid Research Clinic's Coronary Primary Prevention Trial, the early landmark study providing, quote, definitive evidence that lowering high blood cholesterol reduces the risk for coronary heart disease, end of quote. The claimed final proof of the lipid hypothesis. And second, the Jupiter trial, which is one of the studies used to justify treatment of everyone at risk regardless of cholesterol levels. The LRC was portrayed as the long-sought proof of diet and heart disease. On a current NIH website, I found this. In January 1984, the Lipid Research Clinic's Coronary Primary Prevention Trial provided the long-sought definitive evidence that lowering high blood cholesterol reduces the risk for coronary heart disease. We can decide for ourselves as we go through this article whether we agree with this assessment of the study. It was published in two articles in the same issue of JAMA in 1984. Almost 4,000 men with cholesterol levels in the top 1% for the population. Red flags. Relative risk is emphasized over the absolute risk. The relative risk reduction was 19%, but the absolute risk reduction for the composite was 1.6%. Soft endpoints, non-fatal MIs, were used. Non-fatal MIs included those with cardiac pain, and we know how difficult this determination can be, and those with equivocal enzymes and equivocal EKG. The only hard endpoint, all-cause mortality, was not statistically significantly different. The definition of significance was changed after the data were accumulated. The pretrial protocol called for a level of certainty of p less than 0.01, but this was not achieved, nor was the standard two-tail criteria of p less than 0.05. The authors used a one-tailed test to call the results statistically significant. This was harshly criticized at the time and considered by some to be flagrantly dishonest. Misleading claims were made. The statement that the view that LDL is intimately involved in atherogenesis is sustained is false. There is nothing in the article to justify this claim. And the claim that those with coronary heart disease were excluded is false, as the study included men with positive stress tests. Lastly, 1% results from 1% of the male population were extrapolated to the entire population. So overall, is it fair to call this the final proof of the lipid hypothesis? The Jupiter trial, almost 18,000 men and women with reasonably low LDL levels, but with elevated CRPs. They were given Crestor or placebo. It was planned for 5 years, but stopped at 19 months due to unequivocal evidence of benefit. Significantly reduces cardiovascular morbidity and mortality. Now, to be fair, these statements are not from the article itself, but from press releases at the time the study was terminated. Before we go on with the red flags, I need to acknowledge the article at the bottom of this slide. It is a detailed critique of the Jupiter trial, and I use this article to guide my own review of the study. Red flags. It was sponsored by AstraZeneca, which has a commercial interest in the outcome. AstraZeneca collected the trial data and monitored the study sites. AstraZeneca investigators controlled and managed the raw data before it was transmitted to statisticians. The lead investigator is a partial owner of the patent on the CRP test used in the study, and the majority of co-authors had financial ties to AstraZeneca. Members of the Data Safety Monitoring Board that ended the study early had ties to the pharmaceutical industry. The chairman was an investigator of the Clinical Trial Service Unit of Oxford University, and I want you to remember the Clinical Trial Service Unit, the CTSU, as we will discuss this unit later. Soft and hard endpoints were lumped together. The composite endpoint included any MI, any stroke, arterial revascularization procedures, and unstable angina, and when non-fatal MI and non-fatal stroke were removed, the differences between the groups were not statistically significant. The data generated was not consistent with the disease being studied. The mortality for myocardial infarctions is far below what was expected. It was only 8.8% in the placebo group, and no explanation was noted for the low sudden cardiac death in the study population. The results for patients with an elevated CRP, and these were women over 60 or men over 50, were extrapolated to the entire population. And the study was stopped with claims of unequivocal reduction in cardiovascular mortality, but no specific data on cardiovascular mortality is given in the data published. This study gets the red flashing light. Now, there have been many trials completed between the LRC and the Jupiter trials and trials since. Here is a partial listing of the alphabet soup of acronyms for cholesterol studies. You will find multiple red flags and red flashing lights within them. For the sake of argument, if we grant the possibility that most people without known heart disease may not benefit from statins, what about diabetes? Is the following statement true? All adult diabetics should be taking a statin. I've received this therapeutic alert, and I assume that many of you have received similar alerts. Diabetes without lipid-lowering therapy, an analysis of prescription claims, suggests that your patient has diabetes and is not on lipid-lowering therapy. Studies show that lipid-lowering therapy can help individuals reach their cholesterol goals and prevent cardiovascular complications. In other words, review of prescriptions shows that you have a diabetic patient and you've not prescribed a statin. Statins are important, and this suggests that perhaps you are not doing your job as a physician. The sole justification given for this alert is the American Diabetes Association position statement of 2012. I decided I needed to look at this statement closely, including all the studies referenced as having to do with statins for diabetics without known heart disease, and I did so. The first study I came across was the ASPEN study, the Atorvastatin study for prevention of coronary heart disease endpoints and non-insulin dependent diabetes. Robert Knopp is a professor at the University of Washington working at Harborview, and the ASPEN study included about 2,400 patients. About 500 of these had a history of myocardial infarction or coronary artery disease intervention, and about 1,900 did not. This study did not confirm the benefit of statins for the majority of diabetics. Now, it is possible that this study would not have been published or might have been given an entirely different spin if done at another institution. Institutions differ in their policies regarding contracts with pharmaceutical company sponsors. The University of Washington is among the institutions noted for the integrity of their rules for contracts with pharmaceutical companies. They do not allow the contract to be secret. They do not allow the sponsor to control what is published. There is no gag clause, and there is no veto power over what the investigators can publish, and they do not allow ghost authorship. I'm going to digress for a few moments and discuss potential problems with contracting with pharmaceutical companies. There are constraints on publication rights. In the first study, in half the protocols, the sponsor owned the data and needed to approve the manuscript or both, and this fact is not mentioned in the published paper. In the second article, 50% of academic centers allowed ghost authorship, and in 41% of the centers there was allowance of the sponsor to prohibit the investigators from sharing the data. In other words, they allowed a gag clause so that they could control whether the article would be published and what spin to give the results. Ghost authorship is a problem. In this Senate committee hearing, one medical journal editor estimated that 1/3 of the submitted articles he reviewed were ghost authored. In the second article on this page, ghost authorship was identified in the majority of industry-initiated trials, and lastly, 21% of the articles published in major medical journals in 2008 had evidence of ghost authorship. So ghost authorship is a problem in our medical literature. All right, back to the Aspen study. The Aspen study was not free of red flags. It was sponsored by Pfizer. A composite endpoint was used. The design was changed when insufficient numbers were recruited with a history of myocardial infarction or intervention for vascular disease, for coronary artery disease, were recruited to have it be the planned secondary prevention study. So recruitment was open to primary prevention patients, that is those without known coronary artery disease. And due to a change in the cholesterol treatment guidelines made by the National Cholesterol Education Program during the study, the Data Safety Monitoring Board adjusted the protocol for that change. And although it was not a perfect study, it did not confirm the benefits of statins for most diabetics. I next came to the CTT 2008, the Cholesterol Treatment Trialists Collaboration, and the studies within the CTT. The CTT 2008 is a meta-analysis of 14 trials containing almost 19,000 patients. The conclusion reached was that about 1 in 25 patients would be spared a major cardiovascular event over a 5-year time span. Well, this seemed important, so I proceeded to look more closely at the trials included in this meta-analysis. The highlighted trials contain more than 80% of the patients, and I decided to begin with these. The first is the CARDS trial, the Collaborative Atorvastatin Diabetes Study. Almost 3,000 patients, atorvastatin versus placebo, stopped early due to a 36% reduction in cardiac events. And this study is used as the only evidence for the American Heart Association Evidence Statement 33 in the current guidelines. The subjects had type 2 diabetes without a history of coronary artery disease and reasonable LDL levels and at least one risk factor. Very strong conclusions were made, basically saying all diabetics should be receiving statins, and there is no excess adverse events that were found in this study. This study does get the red flashing light. Sponsor Pfizer does have a financial stake in the outcome. Site monitoring, data collection, and data entry was done by staff at Pfizer, and the study was terminated early based on a composite endpoint, not on the hard endpoint of mortality. The lead investigator had a conflict of interest. The composite endpoint included NEMI, coronary revascularization, angina, stroke, resuscitated arrest, and acute coronary heart disease death. And this may be a small point, but this statement troubled me. Sudden death ascribable to coronary heart disease, for which acute myocardial infarction could not be confirmed, were classified as acute coronary heart disease deaths. We've already gone over the unreliability of ascribing sudden death to coronary artery disease. There is an error rate there, and once again, there was no significant difference in all-cause mortality. This troubled me as well. Is this listing of adverse events believable? This is not from a table in the article. I found these numbers in the text of the article, and as you can see, atorvastatin does better than placebo in all of them. Placebo did worse than Lipitor in serious adverse events and in discontinuing the drug due to adverse events, More placebo patients died of cancer, more died of non-cardiovascular causes, and most unbelievable of all to me, and the most troubling of all, are the last three. Muscle adverse effects are a recognized problem with statins, and the debate today is how common this is, not whether or not it occurs. In this study, placebo had more myalgia, more placebo patients had significant rises in creatine kinase, and more discontinued the drug due to muscle adverse effects. Is this believable? This list of adverse events did trouble me. And is this troubling to you, that this study, published in 2004, has this to say about the CTT meta-analysis that wasn't published until 4 years later in 2008? This is the statement. Meta-analysis from the cholesterol treatment trialist collaboration will include CARDS data and will be important in showing unequivocally the safety of achieving very low concentrations of LDL. Now, I could understand a statement that the CTT will be important in evaluating the safety of achieving very low LDL levels, but they did not say that. What they did make was a very positive statement that seems unjustified for a meta-analysis not yet done. And to make that statement about a meta-analysis not yet done, showing something unequivocally, to me, suggests bias. Now, taken together with other statements in this publication, is this article an objective presentation of data or a promotion for the use of statins? Is it science or advocacy? No justification is available for having a particular threshold level of LDL. Patients with type 2 diabetes should receive statins. The debate about whether all people with this disorder warrant statin treatment should now focus on whether any patients are sufficiently low risk for this treatment to be withheld. And the statement we've already discussed about the meta-analysis not yet done. These statements troubled me. It impressed me more as advocacy than science. The heart protection study. The full study had more than 20,000 patients with coronary artery disease, other occlusive arterial disease, or diabetes, and there were almost 6,000 patients with diabetes. Patients were randomized to simvastatin or placebo, and the study found significantly decreased composite endpoints and mortality. And as we discussed, I think it is very reasonable to look very closely at overall mortality. There was a pre-randomization run-in phase to the study, which included 4 to 6 weeks on simvastatin. 1/3 of the patients were eliminated in this phase, and this indicates to me that any statement in the full study about adverse events must be regarded with skepticism, because many patients prone to adverse events may have been eliminated during this pretrial run-in phase. Red flags. It was sponsored by Merck. We see the CTSU again, and we will get back to this. Relative risk was emphasized, but the 1.5% absolute risk reduction for mortality seemed important enough. The problem for me with this is that this was for the full group of diabetics, half of whom had known vascular disease, and I was left with a question. Was there a decrease in mortality for those without known vascular disease? And I could not dissect this out from the data presented in the study in order to answer this question. The ASCOT study, the Anglo-Saxon Cardiac Outcomes Trial, about 19,000 patients with hypertension and at least 3 other risk factors, one of which is diabetes, Atorvastatin versus placebo. This included about 2,500 patients with diabetes, hypertension, and 2 other risk factors, and it was stopped early for significant reduction in endpoints, that being coronary heart disease death and non-fatal MI. The diabetics from the full study were also evaluated separately in a second publication, and there are some interesting differences in the conclusions of the 2 articles. Red flags. The study The study sponsor had a financial stake in the outcome, and the only place where I could find Pfizer referred to by name was after more than a full page of small print at the end of the article in the acknowledgments. The study was supported by the principal funding source, Pfizer. In the article itself, you find the principal funding source had 2 non-voting members on the steering committee, and data analysis and preparation of the report were done independently of the principal funding source. They do not say that management of the data at the study sites was independent of the funding source. More red flags. No benefit for women seen, and yet the results of the study are extrapolated for recommendations to men and women. And the full study did not show a benefit for diabetics. The result was not significant for 6 subgroups, including patients with diabetes. When reported on separately, the diabetic group did show benefit. This was accomplished by changing the composite endpoint. For the full study, the endpoint was non-fatal MI and cardiac death. This was changed for the separate report on the diabetic patients to a composite that included procedures, arrhythmias, peripheral vascular disease, congestive heart failure, angina, and TIAs. So they achieved the significance not found in the full study by changing the composite endpoint. This is a bright red flag. Once again, there was no difference in all-cause mortality. I think this study gets the red flashing light, but cannot say with certainty. Pfizer did have a financial stake in the outcome, and the study was ended early based on a composite, but it was not clearly stated that the sponsor monitored the study sites and managed the data. Lastly, the first sentence in the abstract of the second article does not say the aim is to evaluate the benefits of lowering cholesterol in diabetic patients. It states this study aims to establish the benefit of lowering cholesterol in diabetic patients, and they did so by changing the composite endpoint. Next is the all-HAT study, the Anti-Hypertensive and Lipid-Lowering Heart Attack trial. More than 10,000 patients, about 3,600 with diabetes. It was sponsored by the National Heart, Lung, and Blood Institute. They found no reduction in all-cause mortality or coronary heart disease events or stroke. I did not find the statistics for diabetes in this article. A clinical trial does produce a large amount of data, the minority of which may appear in the published article. I have to assume that the CTT was able to assess the needed data for their meta-analysis. The CTT-8 is used for justification of treatment of diabetic patients without known vascular disease, but it includes 6 studies dealing specifically with patients with coronary artery disease. These 6 studies evaluate patients who had a history of MI or were status post-CABG or PCI or had angina. The PROSPER trial, the pravastatin in the elderly at risk for vascular disease, about 6,000 patients, 623 with diabetes, who had a history of or risk for vascular disease, no difference in overall mortality. There was a decrease in coronary artery disease mortality, but this was balanced by an increase in cancer mortality. I'm not sure why this study was included in the CTT. It did include patients with vascular disease, and I see this study most often cited due to the statistically significant increase in cancer mortality in elderly patients given statins. And why was the ALERT study included? These were renal transplant patients, and the risk reduction was not statistically significant. And the Air Force Texas Coronary Atherosclerosis Prevention Study, this included only 155 patients with diabetes. And why was this study included in the CTT-8 and not the negative ASPEN study with 2,400 patients? There was a reduction in a composite endpoint, but no difference in overall mortality. I think this study does deserve the red flashing light sign. Merck did have a financial stake in the outcome, and the study was stopped early. The management of the data is not clear. In the acknowledgement, the employees of Merck are thanked for their help in designing the trial and managing the data. But the article also refers to the Spectrum Pharmaceutical Research Corporation being contracted to manage the data. This corporation is no longer active. It was filed in the state of Texas as a foreign for-profit corporation in 1997, and this study began in 1990. 3 of the 10 authors were employees of Merck, and 2 of 10 were consultants to Merck. No change in overall mortality, only 155 patients with diabetes. The West of Scotland coronary prevention study had only 76 patients with diabetes. There was a reduction in cardiac events, but not in overall mortality. The lead investigator receives consulting fees from GlaxoSmithKline, Merck, Pfizer, AstraZeneca, and lecture fees from AstraZeneca and Merck. The majority of authors had conflicts of interest with the pharmaceutical industry, and a composite endpoint was used, mortality not different. So what is the CTT? Who are they? The CTT-8 is the only evidence used to justify the American Heart Association Guideline Evidence Statements 31 and 32 for groups of diabetics with no known heart disease. The CTT was established in 1994 after it was identified that no single ongoing trial would have sufficient statistical power to address some key uncertainties about the effects of lowering cholesterol. It was planned to conduct periodic meta-analyses. I can accept this as a reasonable goal, but I can't help but to remember what one professor had to say about meta-analyses. He changed the phrase we've all heard, "there are lies, damn lies, and statistics," to "there are lies, damn lies, and meta-analyses." And by that he meant that one could mislead with a meta-analysis. The quality of a meta-analysis was completely dependent on the choice of randomized trials included in the meta-analysis. One has to look at the studies included before accepting the conclusions of the meta-analysis. And he pointed out that a meta-analysis should not necessarily be looked upon as a gold standard without evaluating the studies selected for inclusion. There are red flags for the CTT itself. It does have a sponsor, and that sponsor is business. In England, the Secretary of State for Business appoints the 14 members of the MRC, the Medical Research Council. MRC has 27 units, one of which contains the Clinical Trial Service Unit, the CTSU, which contains the CTT, the Cholesterol Treatment Trialists. The MRC does have ties to Big Pharma. If you are curious, you can Google the MRC and GlaxoSmithKline and the MRC and AstraZeneca. In any case, the hierarchy is the Secretary of State for Business, the MRC, the CTSU, and the CTT. The CTT does control the release of data and has denied access to the databases. Rita Redberg, a professor of cardiology and an editor to JAMA Internal Medicine, said, "The CTT will not make their data available to any colleagues or other researchers who wish to study the risks and benefits of statins. The CTT data is not accessible publicly." And lastly, I could find within the CTT-8 no overall evidence for a benefit to overall mortality for diabetics without known heart disease. Composite endpoints were used to show benefit. Now, I found this very troubling. The cholesterol treatment trialists are for the most part investigators for pharmaceutical company-sponsored trials, and listed as observers to the meetings of the CTT are all the major manufacturers of statins. So we have investigators dependent on the pharmaceutical company sponsorship being observed by the pharmaceutical companies. Is this conducive to an unbiased production of a meta-analysis? This is a copy of page 65 of the 2013 American Heart Association Guideline. These evidence statements are for 3 groups of diabetics with no known coronary artery disease, so primary prevention patients. The sole evidence to justify the first 2 statements, 31 and 32, is the CTT-8, and the sole evidence to justify statement 33 is the CARD study, a red flashing light study from the CTT-8. Are these studies of high enough quality to convince you of the need to treat all diabetics with statins? Should all diabetics be taking statins? I simply don't know. I am not convinced by the CTT-8, but I don't know. I continue to recommend statins to my diabetic patients, but should I be, and should you be? If the lipid hypothesis is wrong, and if lowering cholesterol levels is not helpful, by what mechanism do statins show benefit in specific risk groups? Statins block HMG-CoA, and by doing so, they block the mevalonic acid pathway. The mevalonic acid pathway is the primary pathway leading to subsequent pathways. I'm going to discuss 3 of them. The production of nuclear factor kappa B is blocked, and nuclear factor kappa B is important to the immune response and to the inflammatory response. There are those who believe that the beneficial effect of statins for those with known vascular disease is due to its anti-inflammatory effect and has nothing to do with a decrease in cholesterol. Cholesterol production is blocked, but let's remember that every cell in the body needs cholesterol. It is a component of our cell membranes, and cholesterol is needed for the function of our nervous systems. 25% of our cholesterol is in our brains, and the cholesterol is a precursor to many of our hormones. The production of CoQ10 is blocked. CoQ10 is being used by every mitochondria in your body right now for the production of energy. Without CoQ10, we would not make enough energy to survive. I'm not going to go over the other pathways on this slide, but clearly blocking the mevalonic acid pathway has multiple complex consequences, not simply a decrease in cholesterol. Low cholesterol levels after age 50 are associated with increased mortality. True or false? In the Honolulu Heart Program, decreasing cholesterol levels was associated with increased mortality. And in the Framingham study, a 1% drop in cholesterol was associated with an 11% increase in mortality. Low cholesterol levels were associated with cognitive decline. In the Framingham study, lower naturally occurring total cholesterol was associated with lower cognitive measures. And in this Amsterdam study, the combination of a low albumin and low cholesterol level was associated with increased risk of future functional decline. Low cholesterol levels after age 50 are associated with increased mortality. These studies suggest so, but this is admittedly very limited data. Statins are associated with declines in mental acuity. True or false? Matthew Muldoon published 2 studies in which he performed neuropsychological testing, placed subjects on a statin or placebo, and repeated the neuropsychological testing 6 months later. In the first study, he used lovastatin, and at 6 months, patients on lovastatin did worse than placebo. This is a graph from that study. The white bars are for the placebo group, and the shaded bars are for the lovastatin group. In the retesting at 6 months, the placebo group improved in measures of attention, psychomotor speed, and mental flexibility, and the lovastatin group did worse. In the other 2 tests, placebo improved more than lovastatin. In the second study, he used simvastatin instead of lovastatin and used a different set of neuropsychological testing. But again, the placebo group did better, and he concluded statins may affect patients' abilities to benefit from prior experience or to devise performance-enhancing strategies. So, statins are associated with declines in mental acuity? By these studies, perhaps so. I remember one of the first patients I placed on a statin. He was a man in his 80s who was very active mentally. He was writing guidebooks that were being published. He had a very high cholesterol level, and we decided to start lovastatin, believing that we were reducing his risk for cardiovascular disease. Several weeks later, he returned and said he would not take the lovastatin because when he did, he could not think clearly and could not write. And when he stopped it, he could think clearly again and could continue writing. We then tried pravastatin, thinking its lower lipid solubility might avoid the problems with his thinking. But pravastatin caused the same problem, and he declined to take a statin again. He eventually died, but not from vascular disease. And just recently, a patient in the high-tech industry who was on a statin was frightened when he could not remember his home address, and he stopped his statin. His memory returned, and he too has declined to consider taking a statin again. So there does seem to be a concern about the effect of statins on mentation for some patients. Statins are associated with muscle disease. Is this true or false? In this article, statin users were significantly more likely to report musculoskeletal pain. And here only 6 of 22 professional athletes could tolerate staying on a statin. In this study, men randomized to lovastatin had increases in creatine kinase after being placed on a treadmill, and placebo patients did not. This is a very busy slide. The only point of this slide is there is a group of individuals genetically susceptible to a severe autoimmune myopathy when placed on a statin. In this study done in a military healthcare system, statin use was associated with increased musculoskeletal adverse events, especially in physically active individuals. In this review article, 4 types of muscle disorders with statins were identified. Your muscles hurt, your muscles are inflamed, you have muscle cell death, and you have asymptomatic elevations in creatine kinase. So statins are associated with muscle disease. The evidence here seems very strong. Statins lower testosterone levels and cause erectile dysfunction. Is this true or false? In one small study in a cardiovascular risk clinic, 22% of men placed on a statin experienced new onset erectile dysfunction within 6 months. In this study, statin use was associated with a significant decline in serum testosterone level. The study also found declines in testosterone levels. It is not difficult to imagine why this might be the case. Cholesterol is a precursor to testosterone, estrogen, progesterone, as well as to adrenocorticosteroids and to vitamin D. Blocking cholesterol is blocking the precursor to our sex hormones. So statins lower testosterone levels and cause erectile dysfunction. This very well may be the case. Statins cause fatigue. Is this true or false? In this one small study, statin use was associated with decreased energy and increased fatigue on mild exertion. This is a representation of the Krebs cycle, and the only thing I want you to focus on is the NADH on the periphery, the red boxes on the periphery. NADH is at the beginning of the electron transport chain, and that is oxidative phosphorylation. The electron transport chain produces the majority of the ATP derived from each glucose molecule, and ATP is the energy currency of the body. There are 5 complex steps that begin with NADH and ends with the production of energy. CoQ10 is essential for 2 of these 5 steps. CoQ10 is also an important antioxidant, and just as burning gasoline in your car produces carbon dioxide, production of energy in the electron transport chain produces free radicals, or reactive oxygen species. With reduced CoQ10, you have impaired production of energy and impaired ability to clear the free radicals produced in this process. So perhaps this is the mechanism for the side effect of fatigue. In this study of patients admitted with congestive heart failure, low CoQ10 levels were predictive of poor outcomes and mortality. Statins are associated with increased neuropathy. Is this true or false? This is a small study. Patients on statins for more than 2.5 years had 26 times the risk for polyneuropathy over controls. This study also found an association between statin use and neuropathy. So statins are associated with increased neuropathy. By this limited data, it appears they may be. The American Heart Association is an unbiased organization, and the American Heart Association cholesterol guidelines can be trusted. Is this true or false? The American Heart Association is a private organization that has achieved a semi-official status. It was founded with altruistic ideals to share research findings and promote further study of the increasing problem of heart disease. From its altruistic beginnings, it has, however, evolved into an organization about which there are now major concerns about bias. The American Heart Association obtains funding from a variety of sources, including about $5 million yearly from the food industry and more than $30 million yearly from the pharmaceutical industry and makers of medical devices. Food industry companies pay fees for the American Heart Association stamp of approval for specific foods, the Heart Check Food Certification Program. In the past, they gave the Heart certification to high-sugar products like Cocoa Puffs and Count Chocula cereals, but they now have recognized the problems with sugar, and I no longer find high-sugar foods getting the Heart Check. You might find it interesting to look for this emblem as you go through the grocery store. I've seen the emblem on the left before, but recently I could find only the one on the right, and I took a picture of this one on the right with my cell phone. You may wonder what some foods with this heart check have to do with heart health. This study found that the majority of panels writing American Heart Association guidelines and the majority of those leading the guideline groups had financial conflicts of interest. Now, guidelines in general are problematic for us. The first study did involve American Heart Association guidelines. 53 guidelines with more than 7,000 recommendations were reviewed. Only 11% had level of evidence A, that is, based on multiple randomized trials or meta-analyses. 48% had level of evidence C, based on expert opinion or standards of care, which is really no evidence at all. I'm going to skip the second and third articles and go to the quote in the last article. What we may have now are the best guidelines influence can buy. To the degree that this is true, it is a sad state of affairs. So the American Heart Association is an unbiased organization, and the American Heart Association cholesterol guidelines can be trusted. There are reasons to be concerned about bias. There are related problems. 8 of 9 members of the 2004 National Cholesterol Education Program Guideline Committee that gave us the low cholesterol target levels many may still be using had financial conflicts of interest with statin manufacturers. The 2013 American Heart Association Guideline is an intimidating document. 84 pages long if one includes the references. It is a complex presentation of categories of evidence, critical questions, 80 evidence statements, and the alphabet soup of acronyms given in support of the evidence statements. As I worked through this guideline document and looked closely at the studies we've discussed, this quote from W.C. Fields entered my mind. If you can't dazzle them with brilliance, baffle them with bull. Does looking closely at the evidence make your job more difficult? I'm afraid it does. If you decide maybe you shouldn't prescribe statins solely based on the cholesterol level or risk calculation, communicating this to patients is tough. It is very tough, and it may leave you medically liable. You have a 76-year-old woman without complicating disease. She's being treated with a statin for an elevated cholesterol, and she's now having muscle pain. What do you do? I suggested to her that she considered tapering and stopping the statin to see if this were the cause of her muscle pain. I explained to her that the evidence for statin use in women without vascular disease was very weak, and there was no evidence that it would prolong her life, and there were concerns about statins in the elderly. She looked at me as if I were the Grim Reaper himself. Didn't I know that if she stopped her statin, her cholesterol would go up and she might die of a heart attack or stroke? These conversations with patients can be difficult. You see a 40-year-old without a history of coronary artery disease or any other vascular disease, and he's worried about an LDL of 136. What do you do? Do you tell him that he should continue his current healthy lifestyle and not be overly concerned? And if you do this and he has an MI in the future, will you be medically liable? Although he did not need a statin by the new American Heart Association risk calculator, I have seen patients like this started on statins by other providers. A 74-year-old diabetic maintains her A1C less than 7 with diet and oral medications, no history of cardiovascular disease. She does not want to start any new medications. Do you encourage her to take a statin? Do you tell her that she is diabetic and she definitely should take a statin? Or do you support her preference and tell her that it is reasonable not to take a statin? A 63-year-old man who has well-controlled hypertension and reasonable cholesterol levels uses the American Heart Association risk calculator, and it states he should be on a statin of moderate to high intensity. What do you do? Do you tell him that given the risk calculator result he should be on a statin? Or do you tell him the evidence that he will benefit is weak and there is no benefit to mortality? Will you be liable if you don't recommend a statin? This is not going to be a rare problem for us. It is estimated that 87% of men over 60 will be getting the recommendation to start a statin by the new risk calculator. This case was an easy one for me. It is me, and I don't plan to start a statin. A 32-year-old woman tells you she was following a healthy diet and has eliminated eggs to be sure she isn't having too much cholesterol, and has a cereal for breakfast to replace the eggs. How do you respond to this statement? Do you congratulate her for making a real effort to be healthy and follow current dietary recommendations to limit the saturated fat and cholesterol in her diet? Or do you tell her there is no evidence that having eggs is harmful to her and she should enjoy her eggs? She may epitomize what has happened to our entire population. In an effort to reduce saturated fat and cholesterol, we've increased our carbohydrate and sugar consumption, and there is growing evidence that this dietary change in the population has resulted in increased obesity, metabolic syndrome, and diabetes. Perhaps it would be healthier for her to have her eggs and cut out her sugary breakfast cereal. This is a provocative quote from a former associate director of the Framingham Project. The diet-heart hypothesis has been repeatedly shown to be wrong, and yet for complicated reasons of pride, profit, and prejudice, the hypothesis continues to be exploited by scientists, fundraising enterprises, food companies, and even government agencies. The public is being deceived by the greatest health scam of the century, certainly a disconcerting statement. And I'm going to give several more quotes simply because I like them. One of the first duties of the physician is to educate the masses not to take medicine. When all think alike, no one is thinking very much. About almost any subject, there are the facts that everyone knows, and then there are the real ones. What passes for knowledge is often no more than well-organized ignorance. Half of what we know is wrong, and the purpose of science is to determine which half. And most important of all to me is this one: primum non nocere, first do no harm. This is a cardinal tenet of our profession. First, do not harm our patients. First, do no harm. And my fear is that if we strictly follow the cholesterol guidelines, we may be doing more harm than good for our patients. And I thank you very much.